we'll start with Dr. Gaoyuan Huang. Take it away.
Good morning, everyone. So I hope everybody is sitting in a warm place with light. So today I'm going to present the past and present treatments for recurrent C3G in kidney transplant patients. C3G is a rare disease, but once it happens, it's devastating to the kidneys. Today, the message I would like to deliver is always keep hoping, and the new treatments are on the way. We start with a case as usual. This is a 21-year-old male with proteinuria 9 gram, no hematuria, creatinine 1.3. Patient had a GN workup which showed low C3, normal C4, ANA positive, anti-dsDNA positive, SPAP UPAP negative, viral serology is negative, cryoglobulin negative. Patient had first renal biopsy which showed immunocomplex mediated MPGN with IgG 3+, C3 2+. Treated with mycophenolate steroid rituximab. 2 years later, patient still had persistent nephrotic range proteinuria, creatinine increased to 5, so the patient had a second renal biopsy. Still showed MPGN lesion, but now with the C3 staining 3+, IgG staining 1+. He was diagnosed with C3GN this time. So what is C3G? What is C3GN? How did immunocomplex-mediated MPGN shift to C3GN? C3G is a rare entity that is defined by a proliferative histologic lesion with C3 deposition at least 2 orders of magnitude greater than any other immune reactant on immunofluorescence. C3G includes C3GN and DDD, which are differentiated by electron microscopy manifestation. MPGN is a histologic lesion. In 2015, it was reclassified. Based on deposits on immunofluorescence study, it is classified into immunocomplex-mediated MPGN, complement-dominant MPGN, and IF-negative MPGN. C3G belongs to complement-dominant MPGN in this classification. But at the same time, MPGN is just one of the histologic pattern of C3G. C3G can manifest as messenger proliferative GN, diffuse endocapillary proliferative GN, crescentic GN, diffuse sclerosing GN as well. They may be due to the same pathogenic process but develop at different time of the disease. So the light microscopy manifestation may depend on the timing of kidney biopsy. Up to 16% of patients shift from C3G to immunocomplex-mediated MPGN and vice versa when a kidney biopsy is repeated. There is no clear cut between these two diagnoses. We cannot talk about C3G without showing the complement cascade. So this complement system is activated through 3 different pathways: the classical, lectin, and alternative pathways. Regulators of complements are shown in red, and the sole activator of the complement system, properdin, is shown in green. An increase in alternative pathway C3 convertase formation and activity is the key of C3G pathophysiology. A comprehensive evaluation of the alternative pathway should include serum levels of complement proteins and their cleavage products, functional assays, and genetic testing. These are all possible drivers for dysregulation of alternative pathway. Its variety demonstrates the heterogeneity of C3G pathophysiology. In our patient, he has borderline factor H deficiency and heterozygous deletion of factor H-related protein 3 and protein 1, which is a very common variant. How do we treat C3G of native kidneys? In 2021 KDIGO GN guideline, expert opinion has encouraged the usual supportive measures. For moderate to severe disease, defined as moderate to marked proliferation on biopsy and proteinuria more than 2 grams, the guideline recommends initially using mycophenolate and steroid. If it fails, consider eculizumab. But keep in mind, All above recommendations based on retrospective studies and case series. So these treatments have been not well validated and showed limited benefits. Our patient met the criteria of moderate to severe disease, and he failed mycophenolate and steroid treatment. So we used eculizumab. Eculizumab is a C5 inhibitor, is the first complement inhibitor used in GN, very effective in PNH and atypical HUS. However, not in C3G. It inhibits the binding of C5 to alternative pathway C5 convertase. It focuses on terminal pathway inhibition. An Italian phase 2 trial showed that after eculizumab treatment, all patients achieved terminal pathway suppression, which was demonstrated by normalization of soluble C5b to 9. However, only 3 out of 10 patients had partial remission. While the key mechanism of C3G is the C3 and alternative pathway C3 convertase, eculizumab is just too late to the party and has gradually fallen out of favor. So we need new complement inhibitors to more accurately target the key pathophysiology of C3G. C3G has poor prognosis. In our case, patient didn't respond to eculizumab at all. He had persistent nephrotic range proteinuria. 2 years later, he developed ESRD and started dialysis. Immunosuppressants were stopped after that. Luckily, he got deceased donor kidney transplant 1 year after that. Guess what will happen after kidney transplant? Post-kidney transplant recurrence rate of C3G is 55 to 86%. Recurrent C3G results in 30 to 83% of graft loss. DDD has even higher graft loss rate compared to C3GN. So given the high recurrence rate of C3G after kidney transplant, is there any way that we can do to lower the risk of recurrence when you use eculizumab after kidney transplant as secondary prophylaxis? You can write the answer in the chat, and we will see which one is more popular. Actually, I cannot really see.
No
Kate, can you
volunteers
tell me?
yet. Oh, Brendan says yes. You're ranging from yes to maybe.
Okay. Yes, we did. We started eculizumab perioperatively, followed by ravulizumab, a long-acting C5 inhibitor. Unfortunately, it seems nothing can stop C3G recurrence. 5 months later, even though clinically he was still stable, normal creatinine, no proteinuria, persistent hematuria, protocol renal biopsy showed that there was recurrent C3G. Good news is that there was only C3 strong staining 4+, but no reactive proliferation. How do we treat post-kidney transplant recurrent C3G? We use the same guideline. This patient failed everything. What can I do? Let's see some studies in the United States and see how we have performed in this field. The largest case series in the US about recurrent C3G in kidney transplant are from Columbia and Mayo Clinic. The Columbia study published in 2019 included a total 19 patients, 12 with native kidney C3GN, 7 with native kidney DDD. After transplant, total recurrent rate was 84%. Mayo Clinic study published in 2014 included 21 kidney recipients. Their original diseases were all C3GN. Compared to the C3GN subgroup of Columbia data, it seems Mayo has less recurrent rate, longer median time to histologic recurrence, longer median time from transplantation to graft failure, but a higher graft failure rate. It seems Mayo did better before recurrence, but Columbia did better after recurrence. What made the difference? How did they treat recurrent C3G? In Mayo series, it seems their strategy was most of the time let it be, but at that time, that was 2014, nobody used the eculizumab in C3G yet. So Mayo series was more reflecting the natural history of C3G after kidney transplant. Columbia study published in 2019, so they included cases using eculizumab. Their recurrent C3G and graft failure rate was lower. Not sure whether eculizumab contributed to that, but compared to other treatments, eculizumab did show higher response rate. So is eculizumab the one? This meta-analysis included 12 studies, total 122 post-kidney transplant recurrent C3G patients. It showed that eculizumab significantly decreased graft loss compared to Plex and rituximab, which is also consistent with the observation in the Columbia case series. But why did eculizumab show variable clinical outcomes in Columbia study? Let's take a close look at the 7 patients that used eculizumab. These patients have different genetic mutations or autoantibodies, different plasma C5b to 9 levels, different histologic manifestations. The heterogeneity can even exist in the same patient. The same patient, DDD number 7, had MPGN pattern during the first C3G recurrence and didn't respond to eculizumab at that time, ended up with repeating transplant, then had recurrent C3G again. This time, he manifested as mesangial proliferative pattern and responded to eculizumab. The heterogeneity of C3G definitely contributes to the inconsistent clinical outcomes. Another reason is that, as we explained earlier, eculizumab is too late to the party, didn't target the key point of C3G. We need new complement inhibitors. How can we develop complement inhibitors? We know the target. Our goal is to improve renal survival. How do we evaluate the efficacy of a new drug? First of all, we need to identify indicators that are associated with renal prognosis. This slide looks very boring. I apologize for that, but it's a core slide in my presentation because it's the base when we interpret clinical trials. Based on limited data, we identified 4 efficacy indicators. Their clinically significant improvement may be associated with improving renal survival in C3G. They are proteinuria, rate of decline of eGFR over at least 6 months, C3 staining intensity, and C3G histologic activity score. While there is lack of evidence linking the intensity of C3 staining and disease severity, C3G histologic activity score seems directly correlated with biomarkers of complement activation. The conclusion is a favorable treatment effect on all endpoints would provide convincing evidence of efficacy of a complement inhibitor. These endpoints are used in the clinical trials of new C3G therapies. However, there are some uncertainties. The evidence about the association of each endpoint and renal prognosis or response to treatment are inconsistent. This is the latest graft biopsy result, which is also this patient's 5th graft biopsy. Sadly, after 3 years ravulizumab, his recurrent C3G still progressed. Proteinuria increased to 8.5 gram, creatinine increased to 2. C3 staining decreased from 4+ to 2+. Demonstrated again, decreased C3 staining is unnecessarily related to improved renal function. I calculated the C3G histologic index myself based on our pathology report. Because not everything has a percentage number, so I took diffuse, frequent as score 3. Then it ended up with a total activity score of 15 and a chronicity score of 1. So this patient's kidney biopsy showed it's very active and almost only active, indicating extreme complement activation. So this patient seems a great candidate for complement inhibitor treatment. We didn't repeat all those like complement level test, function test after kidney transplant, but at this moment, the patient still has low C3, normal C4. Okay, let's back to drug development. These are clinical trials of new complement inhibitors for C3G. Some of them already completed. Pegcetacoplan and iptacopan are the most promising ones so far. Both of them target C3 and C3 convertase axis, which, as we explained earlier, is the cornerstone of C3G pathogenesis. Pegcetacoplan is a percutaneous injection. It binds to C3, inhibits C3 binding to C3 convertase, and results in blocking C3 cleavage from all three pathways. LOBA is the phase 2 trial. Valiant is the phase 3 trial. Iptacopan is an oral small molecule that inhibits the enzymatic activity of factor B. Factor B is a key node in the alternative pathway. Its breakdown product BB is the component with proteolytic activity of the alternative pathway C3 convertase and alternative pathway C5 convertase. Iptacopan is expected to have a suppressive effect on both convertases, resulting in an upstream and downstream regulation of the alternative pathway. It also completed phase 2 and phase 3 trials. These trials all showed positive results, but the phase 3 trial of iptacopan excluded kidney transplant, so I will not talk about it here. NOBLE trial was the first prospective randomized control trial of pegcetacoplan versus standard of care in post-transplant patients with recurrent C3G or immunocomplex-mediated MPGN. The control group has 3 patients. The treatment group has 10 patients, included 8 C3G, 2 immunocomplex MPGN. Some of them had more than 1 kidney transplants. Only 13 patients total. That's where we started. Baseline kidney function in both groups are not that bad. eGFR more than 40. Pegcetacoplan group is more active, demonstrated by lower C3 level, higher plasma soluble C5b to 9, and higher total activity score, lower chronicity score. While control group has significant chronicity and the mean activity score was just 3.3, which means there may be not much we can work on in this control group. LOBA trial showed pegcetacoplan significantly decreased proteinuria, C3 staining intensity, C3G histologic activity score. It also inhibits the alternative pathway demonstrated by increased C3 and decreased plasma soluble C5b to 9. eGFR remained stable over 12 weeks in both groups. Pegcetacoplan met all endpoints at week 12, so it may be an effective complement inhibitor. Again, it's uncertain whether this significant proteinuria reduction and short-term stabilization of eGFR are associated with improved long-term renal survival or graft survival. We need more patients and long-term follow-up. The long-term outcomes of these 13 patients are being further evaluated in LOBA as secondary endpoints at week 52, and I believe which is not completed yet. Valiant is a randomized, multi-center, double-blind, placebo-controlled phase 3 trial of pegcetacoplan. 63 patients in pegcetacoplan group, 61 in the placebo group. It included adolescents and adults with native or post-transplant recurrent C3G or primary immunocomplex mediated MPGN. 9 patients were kidney recipients. It's completed and the result was released at ASN 2024. It met all the primary endpoints, decreased proteinuria by 68% across all subgroups. It also achieved decreased C3 staining and eGFR stabilization, and was well tolerated in all groups. But interestingly, this time it didn't show significant change of C3G activity score. We are very looking forward to its final publication. It's a great start and exciting progress. Let's keep hoping. The iptacopan phase 2 trial is a single-arm, non-randomized study. It included all C3G patients, all adults, 16 native C3G, 11 post-kidney transplant recurrent C3G, with eGFR more than 30. In the native cohort, iptacopan resulted in a 45% reduction in proteinuria from baseline to week 12. In the transplant cohort, the median C3 deposit score in kidney biopsies decreased significantly from baseline 3 to 0.5 at week 12. Why did they choose different primary endpoints? In both groups, baseline kidney function was not bad. Native C3G group has significant proteinuria, while transplant group just has mild proteinuria. Since repeat biopsies were not part of the protocols in native cohort, so they cannot use C3 deposit as primary endpoint in this cohort. Blue is the late native kidney cohort, red is the transplant cohort. Iptacopan showed parallel changes in biomarkers of alternative pathway dysregulation in these two cohorts. After iptacopan treatment, serum C3 increased, serum Y-slab decreased, plasma and urine soluble C5b29 decreased, indicating reduced complement activity. Iptacopan is a factor B inhibitor, so its breakdown product BB is supposed to decrease after iptacopan treatment, which is shown in the study as well. I want to point out that in transplant cohort, the baseline serum and plasma soluble C5b29 was not that elevated. It's possibly because the recurrent C3G was at early stage and C3G was not that active in this cohort. 26 entered the extension study, no control group again. Everyone received iptacopan. Cohort A is native C3G, cohort B is transplant patient. The primary efficacy endpoint in transplant group was still C3 deposit score, which further decreased during the extension period. Total chronicity score was stable, except one patient who had increased chronicity score, and the eGFR was stable as well. So in summary, immunocomplex and PGN can shift to C3G and vice versa. The pathophysiology of C3G is dysregulation of the alternative pathway, and the key point is C3 and the alternative pathway C3 convertase. C3G has high recurrence rate after kidney transplant, and the recurrent C3G results in significant graft loss. Ecudisumab has limited benefit in native kidney C3G and post-kidney transplant recurrent C3G. Pegcetacoplan and iptacopan trials showed exciting results in post-kidney transplant recurrent C3G, and maybe our new hope. So, and we have talked a lot about Columbia and Mayo data a lot. What about UW data? That will be the topic of my next presentation. Stay tuned. We're getting pegcetacoplan for our patients. We will see. At last, I would like to thank Dr. Jefferson for his guidance in my presentation and also in my project. Thanks to Dr. De Castro for sharing the case and reviewing my slides. And also, of course, thanks to my mentor, Dr. Ng, for being my mentor and my cheerleader. Thank you.
Thanks, Gaoyuan. Thanks for taking on a really complicated and rapidly evolving topic. Good use of cliffhanger. We'll be on tuned in for next time. Any questions for Gaoyuan? Feel that the go ahead, Suzanne.
Yeah. Sorry. This is amazing. I love seeing new therapies, innovation in the field of treatment for patients with kidney diseases. How, you were talking about the trials, and I'm assuming drug companies are providing the medication, but I don't know. I'm kind of curious because I just want to know that if this really does show all of the promise and the hope that you're implying that it might, how would we be able to pay for this? Are insurance companies going to provide this? And I don't know if other people have answers to that. I just hope that ends up not being a barrier.
I don't know the answer. Maybe Yuan can help me because Yuan used the medication for compassionate use in one of the patient. I don't know what's the situation now, but there's a lot of paperwork for us to do before we can get the medication at this moment.
So
Yeah,
I think,
Go
sorry.
ahead. No, go ahead, Iris. Go ahead.
Yeah, so Yuan did the compassionate use. So the Pixitacoplan currently is under early access program. So from Apellis. So Apellis will provide the patient fee at no cost for the patient. But like what Gaoyuan said, the bottom line is a lot of paperwork. For this particular patient, I'm currently doing those paper work that includes IRB actually from UW, et cetera, and back and forth, of course, with Apellis. But it's currently early access, and I think, of course, they're pending FDA approval. I haven't gotten a timeline from them when the actual FDA approval is, but for now, if the patient is under early access program, then it's at no cost from the drug company.
Thanks, Iris. And Gaoyuan, great presentation. It really drew me in, at least. So thank you for presenting that.
I'm curious, Gaoyuan, how these considerations, the high recurrence rate, this kind of evolving treatment option landscape affects how folks are determined to be transplant candidates, whether kind of some of this might be in place. I don't know if you're familiar either, but I'm curious about how those kind of considerations might change as these treatment options change as well.
I'm not aware about other studies to evaluate whether recurrent C3G, like C3G as initial diagnosis, as the initial etiology of the ESRD would be a barrier for the transplant. But I know there was a study about, I think, it's CFHR5, that group of people, because that is from Cyprus people, they got that mutation and got a lot of C3G. But the conclusion is it shouldn't be a barrier for transplant. And also just want to say, because there is no clear cut between the C3G and the MPGN, and we have a lot of MPGN patients. MPGN, including C3G, has the highest recurrence rate among all those GN. So we cannot say no to so many people, I guess. We just want to figure out how can we avoid those recurrent C3G, or how can we treat those recurrent C3G. Okay, I want to advocate for myself. So because we're doing this kind of study, so if anybody has C3G patient after transplant, just let me know. Thank you.
I think they'll take you up on that. Right. Well, thank you. Thanks for that. Thanks for that talk.